Hey, everybody. Good afternoon. It's 4 o'clock in the Rocky Mountains, which means it's 6 o'clock on the East Coast. And there is only one place you need to be, and that is right here. Fertility with Fink and Friends. I am Fink. You are Friends, and it is great to see everybody again. Gosh, I was out last week, a little under the weather, still trying to recover here. I have some thoughts about that, and I will share it with you in a moment. But let me just say it is my favorite pardon me, favorite time of the week to be here. 6 o'clock on the East Coast and 3 o'clock on the West Coast, which means 5 o'clock in New Orleans, right? So, hey, it's 5 o'clock somewhere. So nice to see everybody. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado. We do this every Tuesday afternoon. That is when I'm not out sick. So let's see who's joining us here. We've got a couple of different feeds going on. We have two different Instagram feeds. Here's CNY's, or rather, here is CNY's, and here is mine. That's Randy Fink MD. Here is YouTube and Facebook. And LinkedIn. So great to have everybody here on a beautiful Tuesday afternoon. Oh, it's 55 degrees outside here in Colorado Springs. We had a little snow this week. Let me just say hi to all the folks. Hello, Sam. Hello, Mrs. Vince. I hope you are feeling well with your beautiful ongoing pregnancy. My favorite person, Angela, is here. Thank you so much for being here this afternoon. And a special hello to Nurse Anna from the global team, formerly of the office here in Colorado. Welcome. A special welcome to Brandis, our wonderful nurse practitioner here in Colorado. Crystal, thank you for missing me last week. I appreciate you noticing I wasn't there. What's that from Escobar La Chula? Hi, Brandis. I know those lashes are done. I don't know what you're talking about because certainly looks all natural to me. Let's see, Blonde Portuguese Princess, 83 degrees here. I'm not sure where here is, but wherever it is, that's a nice spot to be in. Over on the CNY side, the Owl Theory. I like that name. Good one. Hi to Taylor and Sammy and Coco Fitness and Alicia, Brittany, T. Marie, Viana, Shan Turcoat. Shannon Turcoat. Hello. Carrie Carr. Hi to Kay Hilaria from Las Vegas. Nice to see you with us today. Let's see. The Emerald, it looks like 88, lives in Florida. Glad to have you here. Okay, so let's see. I wanted to, and hello from the UK to Coco Fitness. I wonder what time it is over there. Thanks for being here. Thanks so much. And hi to Mrs. Garcia from San Antonio. All right, I used to be a real conspiracy theorist, and I always, part of me still wonders, is it possible that, we actually have the cure for something like the common cold, but, the cold medicine industry makes something like, I don't even know the number, $20 billion a year. And so is it in the pharmaceutical industry's interests to actually, cure the common cold? I think the answer to that would be, well, somebody's going to make money from it. So certainly if they have a cure, they'll want to sell that. But I don't know. It's always been one of those things that I have to wonder about, because what a design flaw it is that we have these upper respiratory illnesses that can cause such an amazing amount of grief and strife in our lives. Now, I didn't have COVID last week, but maybe I had RSV. I've had a flu shot. Maybe it was the flu. Pardon me. I didn't get it. I wasn't tested because honestly, it probably doesn't make a whole lot of difference. My temperature got as high as 105 degrees. Can you imagine? 105. I actually could feel and hear the brain cells popping there. And as I was lying there, what certainly felt like my deathbed, I started thinking, what is it as humans that make us susceptible to this type of situation? That viruses have figured out how to replicate and transmit between us so that they can keep themselves alive. I don't know. The whole thing is really kind of interesting. And then, of course, that led me to start thinking about fertility issues, and why is it that some people can procreate like jackrabbits and others have a difficult time. And even maybe there's some point in our lives where we're procreating like jackrabbits, and then when we're really ready for it, those things change. These are very interesting and pondersome questions, and I wish I had answers for them. But nevertheless, I'm glad that we are here together and that we can go through this process, and that nobody has to be alone, and that we're in the place to be able to do whatever we can do to try to help you get to where you want to be. Hello, also on the Facebook side, I see Emma Rose and Tiffany, Lisa Marie, Chloe, and Jessica. Thanks so much for being here this afternoon. Let's start with some questions. It looks like Mags Cambor. My question is, does low sperm morphology influence the IVF process? So, what is sperm morphology? When we look at sperm under the microscope, and actually, you know what? I did a video the other day, a little Instagram post, and I'll probably put it up tomorrow, just talking about we can actually do a semen analysis from home, because my question was, and you'll see this when I post it. Hey guys, how many of you are super excited about doing a semen analysis? Nobody's answering, because most people don't really love that sort of thing. But you can do it at home. They're home collection kits, and that's what I talk about in my post. I think I'll put that up tomorrow. So there's some different things we look at in a semen analysis. We look at, pardon me, we look at the sperm count. How many sperm are there? We look at the way they are swimming. That's called their motility and their forward progression. Are they swimming kind of in the right direction? And we also look at what is known as morphology. You may have seen, and if you haven't, please look at my Instagram. Actually, I think I put that on CNYs as well, about what sperm morphology means, and when we what different types of sperm abnormalities are like under the microscope. That's up on, I think, both Instagrams there, and it's worth looking at, because the last one is something that's called a sperm with a perm. And you'll see. Look at it if you didn't see it. Anyway, morphology means, what do the sperm actually look like? So sperm have a head, sperm have a neck, sperm have a tail, and they can have defects in any one of these things or multiple things. And someone's job is to look at sperm under the microscope and determine what percentage of them are normal. Well, in fact, it's amazing to realize that what's normal is that 96% of sperm can be abnormal. It's normal that only 4% of sperm are of normal forms. Now, that issue with morphology is not considered to be reproducible. That is to say that different technicians can look at a sample and may come up with a different number. So it's not all, a sperm count should be pretty close between different laboratories, but sperm morphology may differ because it's subjective depending upon the person who is looking at them. Well, sperm morphology, or abnormal morphology, which is what's known as teratospermia, is not considered to be a cause of infertility. However, it is an association with people who have what we'll call subfertility. So in other words, people who present to a fertility center, there's a high incidence of teratospermia. But in the general population, there's probably a relatively high incidence of teratospermia, but we're not testing them. So it's not considered to be a cause of infertility. Does it influence the IVF process? Not specifically, because remember, in IVF, when we retrieve an egg from you, and that egg goes to the lab, and we have partner sperm, the embryologists are taking one sperm and placing it inside each egg. So we have the ability to be able to select a normal sperm. So even if a count says, well, it's 0% normal forms, in reality, there's probably one in there that's going to look normal that can go inside the egg. So teratospermia probably doesn't have a great big effect on the IVF process. Now, there's one thing that we've talked about here before and has become a topic of conversation, and that is a sperm preparation method that you may be familiar with. It's called Zymot. Zymot. And you can look at their website because it's an interesting website. There's a physician side, or rather a provider side and a patient side that explains what it is. Zymot is basically like a little obstacle course. We put sperm in one side of the obstacle course, they swim through the obstacle course, and the best and the strongest come out the other side. So it's a sperm preparation method that in theory allows us to also select the best and the strongest sperm, the ones that have the least amount of what we'll call DNA fragmentation. Because again, what is a sperm? It's a little package of genetic material with a motor on it, right? So you want that genetic material to be the most normal thing possible. Zymot helps us to select out that better sperm. It's an add-on here at CNY. CNY does not mark it up. It's I believe, a $200 add-on. There are some clinics that charge $1,000 for it, but we basically, I believe, charge what they charge us. It's a very straightforward add-on, especially I think for folks who are known to have had sperm issues before. You have to have a sufficient sperm count, and you have to have sufficient motility, number of sperm moving, in order to be able to use the Zymot. But particularly in couples who have unexplained infertility, I'm feeling that Zymot is probably a reasonable choice, a reasonable thing to do. So that hopefully answers your question there, my friend. Tiffany is 2 days away from the first beta from your first FET. So we are going to keep our fingers crossed for you there, my friend, for sure. And hi to Lisa Marie. Chloe asks, I am wondering what your thoughts are on starting mini IVF with a fatty liver. Let's talk about fatty liver because, this is something that we all really should be aware of. There is a condition, and it's called fatty liver, also known as non-alcoholic steatohepatitis, or NASH, as it gets more extreme. So basically what happens is, and I will tell you that fatty liver is the number one cause of abnormal liver function tests in the United States. So if you've ever had a blood test done and maybe one or both of your of what's called the transaminases, the AST and the ALT, also known as the SGOT and the SGPT, these are the older names for it, come back abnormal. The most common reason is because of a fatty liver. Now, what is the liver? Well, as long as we're looking, so the liver lives basically right here. It's in the right side of the body. I can actually tap and hear it. And why does that actually do anything? Well, it's a good question. So here's Fink's physical exam course. If I tap here on you down in the lower abdomen area, that is, it sounds hollow. Why is it hollow? Because we have a bowel inside, and that bowel is full of air. And I always recommend, feel free to keep that air to yourself. Thank you very much. If I tap on you up here in the chest, it also sounds hollow. Why is that? Because we have lungs that are under the chest wall here that are also full of air. Well, there's a big blood-filled organ that's between those two things. And so if you tap, let's say you sit in the bathtub tonight or you lie flat and you tap, you will hear the difference in sound as you tap upwards into your chest. And that's because that's your liver. So we can actually tell the size of the liver. The liver's job is to detoxify things. It is our big detoxifying organ. And one of the things it will do for us is to store some fat as a source of energy, pardon me, for when our body needs it. Well, too much of a good thing results in fatty liver, and that is where the fat infiltrates into the liver and starts to cause distress in those liver cells. They start crying out, and that's when the liver blood tests start to go up, and that's what's known as NASH, or non-alcoholic steatohepatitis. Steato means fat. Hepatitis is that it's an inflammation in the liver. Non-alcoholic, because alcoholic liver disease is also unfortunately very common in our culture, but this has nothing to do with alcohol consumption. It is really purely a metabolic issue of diet that is associated with basically kind of poor health markers. It's often associated with diabetes and prediabetes, certainly insulin resistance, and things that are bad. So who else is associated with insulin resistance? Well, patients with polycystic ovarian syndrome. Insulin resistance is a mainstay, is a big part of that process. And so it's very common that we see fatty liver in our patients who are undergoing fertility care. People who are thin can have fatty liver. People who are obese can have fatty liver, or anywhere in between. There are some dietary things that are associated with it, and there's not a whole lot you can do about it besides exercise, weight loss. There's no medicine that you can take that miraculously, kind of makes that go away. But blood sugar control and insulin treatment, treating that insulin resistance is the best thing to do. It doesn't have a direct effect on IVF, but it's a very common problem. And especially even in primary care or in gynecology, it was something that I would see quite literally every single day. And I would be willing to bet that a large number of you have some issue with fatty liver. If you have a liver function test done as part of a regular blood test, and those LFTs are mildly elevated, fatty liver is the most common reason for that. It can also be identified on ultrasound or imaging. But so pay attention to what you're eating, pay attention to diet, and that's the best thing you can do for it. You decrease consumption of things like high fructose corn syrup and sodas and so forth. It's kind of a big thing there. So hopefully that answers that question. 20 minutes after the hour. Good. We're only barely getting started here. Fertility with Fink and Friends. I am Fink and you are friends, and let's see if we can get some questions answered. So exciting from Mrs. Christy Lauren, having an egg retrieval in the next 6-ish days. Can't wait to see you. We got a lot of folks who joined in over here. Hi, Mevish. Nice to see you. And hi, Andre. Let's see. Shabnam says, how effective is Omnitrope to add to the protocol? Okay, so Omnitrope is human growth hormone. And let's talk about this too, because this is a hot topic right now. Omnitrope we have recommended for a long time to help people who have issues with egg quality. But it has been in short supply. So some of the pharmacies have not had it in stock. There are, so if you're trying to get Omnitrope and our prescription team tells you, or the pharmacy tells you, I'm sorry, they don't have Omnitrope. There are other alternatives to Omnitrope. Just say, what about the alternatives? So what I've taken to doing when I'm writing it in orders is I'm ordering the Omnitrope, but also saying or alternative, so that hopefully everybody who needs growth hormone can get growth hormone. Why do we give a damn about growth hormone? Well, growth hormone is what keeps us young. So as we age, our growth hormone levels start to go down. And that's one of the causes of aging itself. The same happens, as you know, at the level of the ovary. So, the thing about sperm, the sperm that's produced today was manufactured about 3 months ago. So it's a 3-month-old sperm. And that's the best a guy can do. Act like a 3-month-old, whereas the eggs that you have in your ovary have been there from the time, actually since before you were born. So if you're 30 years old, the DNA that's in those eggs in your ovaries is 30 plus years old. If you're 45, that DNA is 45 plus years old. And as we mature, the DNA in our eggs becomes less stable. And that's one of the reasons that it's harder for us to get pregnant as we get older. It's harder for us to produce eggs and to make normal embryos as we get older because of that DNA issue. And that's what we call egg quality. So there are some folks who have no good reason that they shouldn't have good egg quality. I may have a 25-year-old who had a tubal ligation who's now doing IVF who has an egg quality issue. And they really shouldn't. Now, I would expect that at 40 years old, but I wouldn't expect it at 25. One of the things that we do for folks to try to treat this egg quality issue is to use growth hormone. Growth hormone may have the ability to help to correct some of the age-damaged DNA that's in those eggs. How does it exactly work? Well, I don't think anybody's really sure. There are some studies, and it is controversial. There's some studies that say that growth hormone is just an expensive add-on that really doesn't make any difference in the outcomes. I will tell you that at CNY, we commonly use growth hormone, and I personally have seen it make pretty significant difference in the outcome. So I personally am a believer. I'm disappointed that it costs what it does. There used to be a coupon where you could get it for free, but I don't think they honor that coupon anymore. How effective is it? I think for folks with egg quality issues, Omnitrope is a very useful add-on. Now, one other thing I want to mention, and this is an important thing for everybody who's listening. There is a supplement that's called Omnitrope. No, that's the growth hormone. There is a supplement that's called Serovital. And there are many of us who recommend Serovital as a supplement in IVF because it is designed to increase your growth hormone levels. I used to be one of those people. I very aggressively recommended Serovital because, hey, if you can increase your own growth hormone levels, then that's probably a good thing. It's an herbal thing, so how can it hurt? Well, as it turns out, one of the main components of Serovital is an amino acid that's called L-arginine, which is a supplement that you can take. And in fact, for embryo transfer, it is a supplement that is on my recommended transfer protocol. It's part of the evidence-based transfer protocol. L-arginine is an important thing. However, that's for embryo transfer. For egg quality, L-arginine has an adverse effect on egg quality. It can harm egg quality and cause kind of a chaotic growth of the follicles or the eggs together. So since the main component of Serovital is L-arginine, I do not recommend Serovital as a replacement for growth hormone. In fact, if you are doing IVF, I strongly recommend that you don't take Serovital for that reason. Now, the truth is, that's just my personal opinion. The truth there is that Serovital has not been studied for IVF. Or even fertility. So we know, or we believe based on their evidence, that it does increase growth hormone levels, but we don't know what it does in the fertility world. L-arginine has been studied in the fertility world, and we know that it causes egg quality issues, but can help embryo transfer. So for that reason, please don't use Serovital in lieu of your growth hormone. Brandis and I here at this office are very vocal about that to folks who ask us, but we don't always have the reach to be able to tell everyone, because there are some who recommend Serovital, and we don't for that reason. Brittany is here today. Oh my goodness, you helped me get my beautiful baby girl. She is a year old next month. Do not give up. Fresh transfer to embryos. Gosh, that is fantastic, Brittany. Thank you so much for sharing that. It is so inspirational to see these and hear these great stories. I appreciate it. Let's see. What else we got here? Crystal is here. Thoughts on a trigger shot with natural LH surge with ovulation indication or ovulation induction. Okay, so if you are doing ovulation induction or timed intercourse, either one. So, ovulation induction, how do you do that? You take Clomid, you take letrozole. Or in more expensive cases, you can use the injectable medications. We very rarely do that because if you are spending the money for the injectable medications, like Gonal-F or Follistim, I feel very strongly that you should be doing something that's going to give you a very high probability of getting pregnant, and timed intercourse or IUI isn't it. So I typically don't recommend that. But if you're doing ovulation induction, then it is useful to be able to trigger the ovulation when we know that the follicle size is mature, because it helps you to get that sperm to the right place at the right time. Because really what you're trying to do there is to get the best sperm or any sperm to the best egg or any egg, right place, right time. And so what doing a trigger shot does is tells the ovary, okay, you're going to release the egg in a predictable fashion. It's usually about 48 hours later. But sperm can live for up to 5 days. And so generally we tell people, kind of every other day intercourse between day 11 and 17, and you'll probably have enough sperm there. The trigger shot, costs a little extra money, but it just allows you a little more precision in the timing of trying to get the sperm there. So is it helpful? I think it is. Is it harmful? No, it's not harmful. It has a cost to it, and that's really, kind of the only thing. Let's see what else we got. Hello to Brooke and Zamora, Alejandro Zamora. How much is the first visit with you guys? I don't know the answer to that. I believe they have just increased our consult fees to I believe it's $150. I saw an email about that, but I'm not sure when that actually takes place. Hi to Khadijah from Buffalo. Good to see you today. JM Dots. I've had 5 failed FETs with euploid embryos using different protocols. I've just been diagnosed with basal cell carcinoma, which is indeed, it is a very treatable skin cancer. How much impact would this have on failures? I would say probably not so much at all. Basal cell carcinomas or basal cell skin cancers are localized phenomena. They tend to be, they're things that when they spread very superficially in the skin, as opposed to something like a melanoma, which is a high-grade type skin cancer that will spread through the lymph nodes and can spread to the rest of the body. Melanoma can certainly have an impact, and you can, in fact, metastasize melanoma even into a placenta. But a basal cell cancer is a localized phenomenon, and I'm glad you caught it, because those can be removed with really very minimally invasive procedures. Now, Mohs surgery, and yeah, wear your sunscreen, folks. Indeed, but it's a localized phenomenon and should not have contributed to your FETs there. Okay. I find it interesting too how infertility seems to pop up in women in certain careers more than others. 10 months of infertility is a common phrase in teaching. Very interesting. That comes from Shannon Turcott. I appreciate you sharing that. My goodness. Okay, let's see what we got going on over here. Melissa Salustio. Beta came back at 17 basically, 13 days after a day 3 transfer and on boosters. The second beta is tomorrow. Is there any chance I could be pregnant and not just from the boosters? Why keep me on my meds? Well, okay, so I'll tell you this. When I see a positive pregnancy test, even for someone who is on HCG boosters, we have invested a lot to get to this place, right? So I never want to make a mistake that maybe there's a pregnancy growing here. So when you're doing HCG boosters, you're getting the HCG pregnancy hormone in your body. right? And when we do the pregnancy test, we're testing for that HCG pregnancy hormone. So not surprising that your first pregnancy test when you're doing HCG boosters is going to be positive. And I warn everybody about that. What we want to see is what's going to happen on the second pregnancy test. Because if you are pregnant, then the pregnancy itself is manufacturing some beta HCG. All the while, you're getting a consistent amount of HCG in that little HCG booster. If there's no pregnancy, then the second HCG level is going to be about the same as the first one, right? Because it's not coming from any place else except for the shot. If there's a pregnancy there, it's going to be making its own HCG, and we're going to see that number going up. I never tell folks with a low positive pregnancy test the first time to stop taking their meds, because I have seen pregnancy tests. In fact, Brandis and I had this conversation a little earlier. I have seen betas as low as 9. I think that's the lowest I've seen that actually turn out to be ongoing normal pregnancies. But there are some who say, well, that number's too low, so go ahead and stop all your meds. I wouldn't do that, because how difficult is it to stay on meds for 2 more days just to see where that number goes? Melissa, my God, our prayers are with you. Fingers crossed. Okay. Let's see. Comments on Cooper Genomics embryos discarding news. Okay, so let's talk about this Cooper Genomics thing, because that's also very big in the news. There are a lot of lawyers out there who are trolling for folks to participate in class action lawsuits. So I want to be 100% clear on exactly what happened there with Cooper Genomics. So Cooper Genomics is the laboratory that does our PGT testing. They are a scientific company that make a number of different pieces of equipment and reagents that are used in various different laboratory settings, including that in IVF. They're one of the biggest names in IVF. So they had one of the items, one of the liquids or the reagents that was used in IVF, they had a recall on because there was an issue in them. There was some issue with, I believe it had to do with, I'm making this up maybe, I believe it had to do with the pH of that medium, which is the acid base balance of, there was something about that media that was incorrectly manufactured. And so for a narrow period, and I believe it was from about December 5th until I saw the number sometime a little later on in December. So just during that narrow window, and only in our New York locations and in Sarasota, it did not affect the Colorado location. It affected, of course, other companies, other IVF clinics that use Cooper Genomics, which is an awful lot of them. The media was such that it wasn't allowing embryos to grow. So they recalled it. Every clinic is currently investigating who that affected. I will not say that everyone who has been affected has yet heard from CNY, but they will. If you had an egg retrieval between December 5th and let's say during the month of December, in either Syracuse, Buffalo, Albany, or Sarasota, you may not have, but you might have been affected, and then you will hear from us. Cooper is supposedly making good on all those things because many people had embryos that didn't survive. There are questions about lawsuits against Cooper Genomics. Lawyers are always looking for something that they can say, well, we represent the poor affected class. Class action lawsuits are usually a big loser for people who are members of the class. So it wouldn't surprise me if you participate in a class action lawsuit against Cooper Genomics that the lawyers may make $20 to $30 million on the lawsuit, and you as the class member might get $5 or something. The class is never made whole. The lawyers are definitely made whole. So I'm suspicious about class action lawsuits for that reason. Hello to Alana. We haven't seen you for a while. I've been taking L-arginine, among others that were recommended to me in my last consult to increase my odds with the second retrieval. But now I'm wondering if the last 90 days were more harmful in hearing what you said. Arginine, so actually, if you read the book, it starts with the egg, and that's where that data comes from. Arginine is definitely an important thing for embryo transfer. It has a very favorable effect on the lining, but it is said to potentially have issues with egg quality and the growth of follicles. So if you took it, L-arginine is in the environment as well. It's an amino acid. We can't be without it. It's critical to our survival, but I just simply don't recommend it as something to be taken with retrieval. Hi to Kia. I have 3 day 3 frozen embryos. They're graded 1, 4, 2, 9, and 3, 9. Is it unrealistic to transfer only the 1, 4? Is it unrealistic? No, I think you can definitely do that. And here's something I think is really an important thing. Whatever those embryos look like, I have seen some really poorly graded embryos result in some really beautiful babies. So remember that the whole point of embryo grading, and truthfully, with a day 3 embryo, they're not really graded the way a blastocyst is, but the whole point of grading embryos was to try to figure out, can you tell which embryo is normal based on looking at it? And by normal, I say, well, okay, if we correlate that with PGT testing, because we want to know which of the embryos have normal chromosomes. When we have an embryo that has normal chromosomes, that embryo gives us the highest probability of success, and that's about a 65% chance of success. So being a chromosomally normal embryo, most important feature ever. So can you look at an embryo, or can an embryologist look at an embryo and describe certain features under the microscope and assign some value to those things so that we come up with an embryo grade? Can you do that? Yep, that's what embryo grading is. What does it mean? Not much, because when you then take those graded embryos and you do PGT testing on them, you may find that the lowest graded embryo is the chromosomally normal embryo, while the most beautiful highest graded embryos are chromosomally abnormal. So the grading does not correlate with that being chromosomally normal. It's a beauty contest, and poor looking embryos can still result in very normal babies. So I would say, yeah, for sure, you can transfer that lower grade embryo and still have some, have the same reality that of any of the other day 3 embryos. So I feel pretty good about that. Yes, indeed. What time is it? 38 minutes after the hour. We'll be here for another 20 minutes. Are twins possible with IVF? Can they put 2 sperm in? Well, so we will not fertilize an egg with 2 sperm. But embryos can, a single embryo can continue to grow and split and become 2. So 1 can become 2. Plenty of cases of folks who have done a single embryo transfer and end up with twins. Or that's one of the reasons why we don't like to put 2 embryos in if we can help it. There are some situations where that's appropriate, and that has to do with the guidelines from the American Society for Reproductive Medicine. But let's say you have a euploid embryo, a tested embryo. We will almost never recommend that you do 2 euploid embryos. It's against every guideline and against medical advice. Why? Because there's a very high probability that those embryos are going, may both implant. And 2 can continue to divide and become 4. And 4 can continue to divide and become 8. Believe me, it has happened. And we don't want that. So our goal is not to get you twins. And I always tell people, twins, it's a very endearing thought, but it's a very dangerous pregnancy. And so our goal is to get you one healthy baby at a time. Twins are definitely possible with IVF, and sometimes we do put in more than one embryo to increase the rate of pregnancy. It just kind of depends on the scenario and the recommendation, and that's an important thing that we can talk about. Hello to Miss Smile Bright. Is there any hope for those with incredibly low AMH? Pardon me. I've been told my chances with IVF and IUI are about equal and in single digits. So a low AMH only means that the ovarian reserve is low. And what does that mean? It means that our expectation for your response to the IVF medication is going to be low. Kind of hand in hand with that is also the issue about egg quality that we talked about earlier. So there are absolutely things that we can do. There are different protocols we use for folks with a low AMH. It does decrease the odds of pregnancy. And I will tell you that there are many, many IVF practices that if your AMH is low, they will not accept you into their IVF program because they want to be able to show really this artificially elevated success rate. So they don't want someone in who has a lower probability of success. We will help you. And so glad you're here today, Miss Smile Bright. And I sure do like that name. All right, let's see what else we got here. I think I've missed some over here on the Facebook side. Star Ray Elise says, I've had 2 failed FETs. I would like to do a fresh transfer. What determines if I can do fresh versus frozen? So in general, a fresh transfer is done in the same cycle that your eggs are retrieved. So it would mean that you have to do another retrieval. And there's some numbers that we look at hormonally. We want your estradiol level to be less than 3,000, and we want your progesterone level to be less than a 1.5. If your estradiol is greater than 3,000, even if it's not, but you are hyperstimulated, or if your progesterone level is greater than 1.5, the odds of your fresh transfer working are essentially zero. Could it happen? Yeah, it can happen, but very, very rarely. So we will not encourage it under that scenario. And we'll frankly tell you that you shouldn't do it. You're wasting an embryo. But that's really kind of what we're looking at there. So it means you got to do another retrieval, and those hormone levels have to look like it's going to be a hospitable environment for that embryo inside of you. If you have an endometrioma, should you get a laparoscopy for endometriosis? This comes from Andrea Foster. Good afternoon or good evening, Andrea. So an endometrioma is a collection of endometriosis in the ovary. It is what is also known as a chocolate cyst. A chocolate cyst. Why? Well, because if we cut into it, the material that comes out looks like kind of liquefied chocolate. What it is old blood that's collected inside that cyst. So the problem is, well, all right, we know endometriosis can decrease your ovarian reserve. And we know that the presence of endometriosis can also decrease the odds of implantation when you do an embryo transfer. Well, the presence of the endometrioma in the ovary means that, okay, if you're going to have surgery, that we're going to be doing kind of digging around in the ovary in order to try to remove that endometriosis cyst. The problem with doing that is that will almost definitely decrease your ovarian reserve. So in most cases, when we do an egg retrieval, we're able to skirt around the presence of an endometrioma in the ovary in order to retrieve the eggs. So everybody has their own unique scenario there that we'd have to look at. But it always makes me worried to think about operating on somebody to take out an endometrioma before we've done an egg retrieval, unless the endometriosis is just taken up all the space in the ovaries. So certainly something to talk about there. Tiffany says, says following here. Did you say the Buffalo Clinic was affected by the Cooper Company? Listen, I don't want to swear to that. I know Syracuse, Albany, and Sarasota. I may be mistaken. If you were affected by that Cooper media issue, you will be contacted by CNY. Okay, 100%. And I can promise you that part. I know it was Syracuse, Albany, and Sarasota. I think Buffalo was involved in that too. The only thing I know for sure is that Colorado was not included because we were using a different stock of material at that time. So I hope I didn't scare you there. But if you were involved, we will be in touch with you at CNY. Jessica is here, counting down the days. Monday is a consult with Brandis. I want to know if you recommend PGTA, as I'm 25 and have unexplained infertility. Well, so there's two ways to look, Jessica, at PGT. The first is, well, at 25, I'm going to expect that probably 85, 90%, or maybe even more of your eggs are going to be chromosomally normal. So most of the embryos that you are going to make when you do IVF are going to be normal embryos. So doing PGT may not necessarily be worthwhile, because if there's going to be a 90% or 80 to 90% normal rate, wow, that's pretty good. On the other hand, let's say that you make 20 embryos. Wow, that's dang good. Wow, that's incredible. All right, well, if we said 80% of your eggs are going to be normal, and then 80% of your embryos are going to be normal, well, that means that 16 out of 20 of your eggs or your embryos are going to be normal. You might have to do 4 transfers until you got to the first normal embryo. Wow, that's a lot of money. It's a lot of emotional capital to spend in order to get to that point. So what PGT is particularly useful for is to take a large group of embryos and to be able to narrow down which of those embryos, in your scenario here, which of those embryos are going to have the highest probability of being able to get you pregnant. So that it just means fewer unsuccessful transfers. But since you are likely going to make mostly normal embryos, is it a necessity for you? I would say no. It's not something in particular that we say is used for unexplained infertility. Now, if you had a history of recurrent pregnancy loss, that's a different story. But you'll be able to talk about that a little bit more with Brandis next week. We're glad to be having you. Let's see here. Suggestions for the best outcome for an egg retrieval. Had 27 eggs retrieved for frozen, taking all the vitamins, add-ons, no caffeine, no known health issues on either side. So what that sounds like is, so 27 eggs retrieved. I'm not sure if you did IVF, Tiffany. If you did IVF, then there may be an issue there. You had 27 eggs, but only 4 of them fertilized, or were you just doing egg freezing? That sounds like there's an egg quality issue, and so that's certainly something we would want to look into to see what your unique factors were involved with that. Hey, Michelle is here. I'm 55 and postmenopausal. Is it possible to do ovarian rejuvenation and use my own eggs for IVF? Not at 55, unfortunately. The definition of menopause is basically where you have run out of eggs. So we're born with all the eggs that we'll ever have. Over time, we lose those eggs. Now, let's say that you were 45. Even at 45, the odds of successfully getting pregnant through IVF with your own eggs are sadly very, very low. But basically what menopause tells us is that you're out of eggs. So even doing what you call ovarian rejuvenation or doing PRP, platelet-rich plasma within the ovaries, that's something that can be helpful for egg quality, but it can't replace eggs that have already that are already gone. In other words, we can't turn the clock back to make you pre-menopausal again. Now, we can definitely make you pregnant, but it will be with a donor egg. Your uterus doesn't age in the same way that the ovaries do, because the ovaries will lose their egg, but we can wake the uterus back up again. It doesn't have a portion of it that is continually disappearing over time. So hopefully we can help you there, my friend. Oh, let's see. Amara says, I was on HGH for a year and a half. Coupled with intra-ovarian PRP, I finally had some good results. All thanks to Dr. Fink. Well, you said nice things there, my friend. Thank you very much. I appreciate that. People seem to prefer fresh eggs over frozen. Do you know why? Yes, I know exactly why. So when we go to the grocery, right? Fresh vegetables are always better than frozen vegetables, aren't they? Haven't we been taught that since we were all little? Yes, indeed, it is. And so the thinking is, well, then a fresh embryo must be better than a frozen embryo, and that is not necessarily the case. Now, people do get pregnant from fresh embryo transfers, and in fact, at CNY, the fresh transfer is included in the price. And so if you can do a fresh transfer, sure, do a fresh transfer. The success rates are dramatically lower in women over 40. So I don't recommend it as much in that cohort. So there's one reason people think fresh is better than frozen, because that's what happens with vegetables. And secondly, because there is a financial incentive to be doing a fresh transfer here. Because a frozen transfer has an extra cost associated with it. As I say, people do get pregnant from them. If you can do it, not a problem to do it. But expect and understand that a frozen transfer does have a little higher success rate. This comes from Shan. Again, I have endo and just found relatively small adenomyosis, doing down regulation before my first embryo transfer. Would you recommend just our prob for 3-cycle or letrozole and other meds too? Not quite sure what you're asking there, but I think what you're saying is, okay, endometriosis, we've talked about, and that's where that lining of the uterus that normally sloughs off, that would come out when you have a period, instead works its way up inside and implants inside your pelvis and can interfere with the way the brain talks to the uterus and the ovaries. And so adenomyosis is where the glandular lining of the uterus, and that's that glandular lining that becomes the baby blanket that's going to envelop your sweet little embryo and hopefully let it grow. Instead of just sort of sitting inside the uterine cavity, it starts to grow into that muscle. The muscle that is the uterus. So that's what adenomyosis is. How do we treat these things? Well, we typically treat them the same. We downregulate, which is what you're talking about here. We give you one of really 3 different medications. It's either Lupron, and Lupron is the big gun that shuts everything down. It turns off all the hormones, makes your body believe that you are temporarily menopausal. So it has a lot of side effects that are associated with it, but for 35 years plus years, that's really all we ever had to treat with. There are now some other medications. There are 2 oral medications. One's called Orilissa, and the other is called Myfembree. These are both much better tolerated than the Lupron, and the data shows us that 60 days or 2 months of suppression, either with Lupron or with letrozole, either with Lupron or with Orilissa or with Myfembree, improves the odds of a successful embryo transfer. Now, sometimes we add another medication to that. We can add some letrozole to that, which can further the effects. So hopefully that answered your question there. All right, what else we got? We got about 5 more minutes here, so let's see what we can get to. Viana asks, how likely is it to conceive naturally following a salpingectomy or removing a fallopian tube due to a hydrosalpinx. Is IVF the best treatment to conceive? Well, so part of the question there is would be, kind of how old are you? But let's say that you lost one fallopian tube. Well, losing one fallopian tube really does not have a significant impact on your ability to get pregnant. So the pregnancy rates are pretty close without that fallopian tube. And in fact, in point of fact there, Viana, the reason that you had that tube removed was because the tube was full of fluid. And that's known as a hydrosalpinx. A hydrosalpinx, that fluid in the tube, can wash back into the uterine cavity and is toxic to an embryo. So the mere presence of that fallopian tube can actually prevent you from getting pregnant. So now that that's out, it may work. You may get pregnant on your own. Depends on what the other issues are. Issues of egg quality, how old you are, how you ovulate, and of course, things about sperm. So IVF is always going to be the fastest and most effective path to pregnancy, but it's also the most intense and the most expensive. So it may not be the only option for you. Sarge, works in the call center. Well, good afternoon, Sarge, or good evening. It's nice to talk to you. You have a hard job there answering all those phone calls from our patients. Let's see here. Paris Katie says, looking forward to our phone consultation next week. Oh, glad to see you're feeling better. Thank you, my friend. I appreciate that very much. Let's see. Nurtured Shanna says, would you say that Zomactin is as effective as Omnitrope? The answer is yes. Zomactin is one of the brands that is, pardon me, is one of the brands of growth hormone instead of Omnitrope. And so, yes, I think it is equally as effective. Let's see. Can't find Equestrian 33. Can't find Omni anywhere. You recommended it 21 days for me. Is it enough of a difference to push my retrieval back as I keep trying to find it? So what I would do in that scenario is contact the prescription team and say, Omnitrope was recommended. I would like a substitute. So that Zomactin I know is available from Metro Drugs. They have it right now. In fact, I think they may even have, Omnitrope. So, but you can, yes, I would say get a hold of it, get on it right now. And I don't think that you need to push your cycle back. Roxana is here and says, do you recommend Lupron after a laparoscopy? Had both tubes removed and still have stage 1 endometriosis. Resting the uterus until April because the OBGYN removed some bleeding. Stage 1 endometriosis is said to not be a cause of fertility problems, but I will tell you that folks with otherwise silent endometriosis diagnosed in a non-invasive way, we find do better when using medical suppression. So Roxana, I would certainly think about, again, Lupron would not be my first choice, but given that Orilissa and Myfembree are both covered by insurances and they're much easier on you, I'd sure say, gosh, if you're holding off till April anyway, maybe 60 days of some suppression before you do your embryo transfer would be useful for you. So I feel pretty good about that. Michelle is asking, can I get pregnant with my tubes tied? Only if you do IVF or if you have a tubal reversal. Now, when you have a tubal reversal, it still doesn't always work because you're leaving behind some scarring in the tubes. So it does increase the risk for an ectopic pregnancy, or sometimes just the opening doesn't stay open and sperm still can't get through. So tubal ligation is considered to be a permanent sterilization, but easily bypass that by and through IVF. Let's see. Robert and Desiree say 41 and 7 months post sleeve, lost 82 pounds and just had my third and best retrieval 3 days ago in Sarasota. Fantastic. We got 14 eggs and 8 fertilized and are still growing. It's my third IVF, will be my first frozen transfer. Any suggestions prior to transfer? Yes. Okay. 5 supplements that you should be on for embryo transfer: prenatal vitamin, CoQ10, vitamin D, vitamin E, and L-arginine. That's the list. Comes right from the book. It starts with the egg, and I am afraid they are going to shut us off here, people. It's top of the hour now, which means we've been at it here. But we'll be back next week. Please join me again, won't you? It is always so good to see all my old friends and new friends here. I am Fink, and you are those friends. I'm fond of saying what's on the plaque behind me on the wall there, which comes from my friend Jody in embryology, and it's that this fertility business. It's not the book of your life. It is merely a chapter, and we are here to help you rewrite that. So until next week, move forward with kindness, move forward with love, and most of all, move forward with the hope that tomorrow brings great things. God bless you all. Good night.